Welcome back to the deep dive. Today we're getting into a really significant topic, motor neuron disease. You probably know it as ALS too.
Yeah, that's right.
We've got this set of pretty detailed revision notes here. And, well, our mission is to really dig into them, pull out the key stuff, the high-yield info you absolutely need,
hmm
making it hopefully easier to grasp whether you're, hitting the books for revision or just want to understand it better.
Exactly. These notes are pretty comprehensive. They cover the whole spectrum, really. And our goal today is just to boil it all down, make it digestible, and really flag up those key differences and important facts.
So why focus on MND? Well, like the notes say, it's rare, relatively speaking, but it's a devastating condition, progressive neurodegenerative disorder.
Yeah, it's tough.
So let's unpack it using these notes as our roadmap.
Sounds good.
Okay, so basics first. What exactly is motor neuron disease? The notes define it as progressive neurodegenerative, affects voluntary muscles, weakness, atrophy, loss of function.
And that word progressive, you really highlighted it. It's critical. It doesn't stay still. It gets worse. And it typically hits between 40 and 70, usually painless weakness at the start. That's a key feature the notes mention.
Painless weakness. Okay. And it can start like in different places and spread.
Exactly. And the notes break it down into different patterns or subtypes based on where it seems to kick off.
Right, the subtypes. What do the notes say about those?
Well, the big one, the most common, is amyotrophic lateral sclerosis, ALS. That's what most people think of.
Okay, ALS.
Then there's progressive bulbar palsy. That one specifically hits the muscles for, talking, chewing, swallowing, the bulbar region.
Ah, okay, the bulbar symptoms.
And progressive muscular atrophy. This tends to affect the small muscles, hands and feet especially.
Yeah.
And the notes make a really important point here. Muscle spasticity is absent in this type. It's a key distinction.
No spasticity. Got it.
And lastly, there's primary lateral sclerosis. It's rare, causes stiffness, weakness, often starts in the legs but can spread.
So it's grim stuff. Progressive paralysis, eventually fatal, and ALS is the main form. Maybe a way to remember the subtypes is thinking about where it starts, like everywhere, or bulbar, or small muscles, or legs, something like that.
That's a good way to frame it, yeah. Focusing on the initial presentation.
Okay, so we know what it is, but why? Let's talk etiology, risk factors.
Okay.
What did the notes say about the cause?
Well, the first big takeaway from the notes is the exact cause isn't known.
Unknown. So it's likely, a mix of things. Genes, environment.
That's exactly what the notes suggest, a complex interplay. About 10% of cases are familial, meaning they run in families.
Right, inherited.
But the vast majority, like 90%, are sporadic. It just happens. No clear inherited link.
And the notes mention specific genes. SOD1, C9orf72.
Yep, those are linked particularly to the familial cases. And there's this idea, this hypothesis mentioned about oxidative stress maybe playing a role, like problems with mitochondria damaging the motor neuron.
Mitochondria, the cell's power plants.
Right. But the notes are pretty clear, the exact mechanisms.
Yeah.
Still being figured out. It's complex.
So if we don't know the exact cause, what puts you at higher risk? What are the risk factors listed?
Well, top of the list is family history or having one of those gene mutations. Age is a big one, too, usually 40 to 70, peaking a bit later, maybe 60, 80.
Okay.
It's slightly more common in men. And the notes mention possible environmental factors, but without getting specific.
Right. So main risks, according to these notes, family history, age, being male, cause mostly unknown, probably genes plus environment.
Okay, let's dive a bit deeper. Pathophysiology. What's actually going wrong inside the body at the nerve level?
The core problem, as the notes explain it, is the degeneration, the death of motor neurons, those nerve cells in the brain and spinal cord that control our muscles. And here's the really crucial bit that defines MND. The notes stress this. You get dysfunction in both upper motor neurons, the UMNs in the brain, and lower motor neurons, the LMNs in the brainstem and spinal cord.
Both UMN and LMN. Yes, but, and this is key, the LMN signs usually predominate. You see more evidence of the lower motor neuron damage, even though both systems are affected. That mix is a hallmark.
And that SOD1 gene link pops up again here in the notes.
It does, yeah, especially for familial MND. And it connects back to that oxidative stress idea, maybe mitochondrial problems leading to neuron damage. But again, the notes caution, it's complex, not fully understood.
Okay, so main takeaway for pathophysiology. UMN and LMN damage, but LMN signs are usually stronger. That's a really defining feature. So how common is it? Epidemiology, what do the notes tell us about numbers?
It's relatively rare. Annual incidence is about 2 to 3 per 100,000 people.
Okay, 2 to 3 per 100K. affects both sexes.
Yep. But like we said, with risk factors, slightly more common in men. And the age range, again, 40 to 70 is typical onset and reinforces that 5–10% are inherited. So, yeah, epidemiology confirms the risks. Male, older age, family link.
Right. So what does this actually look like when someone presents clinical features, signs, and symptoms?
Well, the notes say it presents in different ways, but the common theme is losing muscle control. So you see muscle weakness, muscle wasting atrophy, muscle cramps are common too.
Okay.
Difficulty with speech or swallowing those bulbar symptoms again, and eventually weakness in the breathing muscles.
And the notes mention cognitive changes sometimes.
Yeah, they do add that. While it's mainly motor, some cognitive and behavioral changes can happen in some individuals. Not always, but it's possible.
Okay, now the notes list some really key diagnostic clues, stuff that helps tell MND apart from other things. This seems super important for revision.
Absolutely crucial. They mention fasciculations, those little muscle twitches you can see.
Right, it twitches.
A really big one. The absence of sensory symptoms. So no numbness, no tingling usually. That's key.
You have sensory loss. Okay.
Then there's the mix of LMN and UMN signs we talked about. Often wasting of the hand muscles is quite prominent.
Hand wasting, okay.
Also importantly, the notes say it doesn't affect the muscles that move the eyes. Eye movements stay normal. And no cerebellar signs, so balance and coordination are typically okay.
Wow, okay, so no eye movement problems, no balance issues.
And abdominal reflexes are usually preserved, and bladder bowel issues tend to only happen very late in the disease.
So why is the absence of those things, sensory, eye movements, cerebellar, so important?
Because lots of other neurological conditions do cause those things. If you see weakness without sensory loss, without eye movement issues, without cerebellar signs, but with that UMN-LMN mix and fasciculations, well, MND climbs much higher up your list of possibilities based on these notes.
That makes sense. It helps narrow it down. And just to recap those LMN versus UMN signs from the note?
Sure. LMN signs, weakness, the atrophy, muscle shrinking, the fasciculations, twitches, and sometimes reduced reflexes, hyperreflexia, UMN signs. Also weakness, but with increased muscle tone, spasticity or stiffness, exaggerated reflexes, hyperreflexia, and that upgoing plantar response, the Babinski sign.
Got it. And it's the combination that's the big flag.
Precisely. The notes also mention different ways it can start limb onset, bulbar onset, sometimes respiratory, and they add a little caveat. While absent sensory symptoms is a key rule, very rarely some pain or sensory stuff can occur, which obviously makes things trickier.
Okay. So clinical picture, progressive weakness, wasting, twitches, maybe stiffness, brisk reflexes, but crucially no numbness, normal eye movements, normal balance. That specific pattern is what the notes point to.
Right. So with that pattern, how do you confirm it's MND and not one of the mimics? Differential diagnosis. This seems vital because the prognosis is so different for some conditions.
Absolutely vital. You have to rule out treatable mimics. The notes highlight a few key ones.
Okay, what are they?
First, benign cramp fasciculation syndrome. Sounds scary. You get cramps, you get twitches like MND. But the notes stress. No wasting, no weakness, no progression. Big difference. Often worse with exercise or tiredness.
Okay, BCFS.
Yeah.
No weakness or progression. Then, cervical radiculomyelopathy. A neck problem pressing on the spinal cord or nerves. Can give you LMN signs in the arms, UMN signs in the legs, a bit like MND. But the notes say look for neck pain, radiating arm pain, sensory loss, and usually no bulbar symptoms. An MRI of the neck clarifies this.
Sensory loss and neck pain point away from MND there.
Ghoul pathologies, like someone has two things going on, maybe neck compression and a separate nerve issue. Again, the notes say you'd likely see sensory signs, probably no bulbar symptoms. Needs tests like EMG and imaging.
Right.
Multifocal motor neuropathy, MMN. Immune condition often causes weakness in one hand or arm, usually in younger men. Key difference. Diagnosed by nerve conduction studies showing conduction block. And crucially, the notes highlight it's treatable with things like IVI, totally different outlet.
Treatable, huge difference. Okay.
And inclusion, body myositis, IDM. It's a muscle inflammation. Causes weakness. Especially finger flexors, the notes mention that specifically. Listed as without sensory symptoms like MND, but needs EMG and muscle biopsy. Prognosis is much better than MND.
Okay, so lots of things can look a bit like it initially. The notes also list things like diabetic issues, GBS, myasthenia, spinal tumors, stroke.
Yeah, the list shows why careful diagnosis is key. But if you focus on those main differentials the notes highlight, you can see the pattern. You're looking for the MND features UM-MLMN mix, fasciculations, often hand wasting, but also the absence of other things like significant sensory loss, pain, cerebellar signs, or specific patterns seen in mimics like MMN or IBM.
So how do you actually confirm it or rule those others out? Investigations. The notes say diagnosis is primarily clinical, right?
That's the main message, yeah. The history and the neurological exam are paramount.
But tests still play a role.
Oh, definitely. But mainly to support the clinical suspicion and, crucially, to exclude those mimics we just talked about.
Okay, so what tests do the notes mention?
EMG electromyography is key. It looks at muscle activity, shows signs of nerve damage like denervation. Nerve conduction studies, NCS, are usually done too, mostly to rule out neuropathies like MMN.
EMG and NCS. Okay.
Neuroimaging is essential, usually an MRI of the brain and spine.
Oh, wow.
The notes stress this is vital to rule out structural causes like spinal cord compression, tumors, stroke, things that could mimic M&D symptoms.
All right, I got to rule out the structural stuff.
Genetic testing might be done, especially if there's a family history. Blood tests are important to check for other causes, vitamin deficiencies, thyroid issues, infections. And sometimes, though less often for M&D itself, a muscle biopsy might be considered according to the notes.
So clinical picture is king, but the tests, EMG, NCS, MRI, bloods, maybe genetics, are all about confirming by excluding everything else. A cautious approach, given the implications.
Exactly right.
Okay, so if it is confirmed as MND, what's the management plan? The notes really emphasize a multidisciplinary approach.
Yeah, that's fundamental. Because there's no cure, the whole focus, the notes explain, is on managing symptoms and maximizing quality of life. And that takes a whole team.
Who's on the team?
Neurologists, obviously, but also dietitians, physios, occupational therapists, speech therapists, respiratory specialists, palliative care. The notes list quite a few. Everyone plays a part.
So what are the main areas they manage?
It's broad. Supportive care, therapies, equipment, breathing support, medications for symptoms, nutrition, and integrating palliative care early on.
Okay, specific interventions. The notes mention one main drug.
Yes, riluzole. It's a glutamate blocker. The notes state it's neuroprotective, and it can extend survival on average by about 2 to 3 months, mainly in ALS.
2 to 3 months, okay. What about breathing support?
That's critical. Non-invasive ventilation, NIV, like a mask ventilator used mainly at night. The notes highlight this provides a significant survival benefit, maybe around 7 months.
Wow, 7 months from NIV.
And nutrition is another big one. A PEG tube, feeding tube directly into the stomach, is also linked in the notes to prolong survival, besides helping maintain nutrition when swallowing becomes difficult.
So NIV and PEG aren't just comfort measures. They actually extend life, according to these notes. Interesting. What about other therapies?
Physio is huge, maintaining joint movement, preventing stiffness, managing pain from tightness. Speech therapy helps with communication, using aids like boards or tech as speech fails. OT helps with adaptations for daily living.
And managing specific symptoms like cramps, stiffness.
Yeah, the notes list treatments for those. Quinine or baclofen for cramps, baclofen or tizanidine for stiffness. Medications like antimuscarinics or even Botox for excessive saliva. Humidifiers for thick saliva. Pain relief using various drugs, including opioids if needed.
And end-of-life care is part of this from early on.
Yes, the notes emphasize that. Planning ahead with advanced directives involving palliative care and hospice services for symptom control, managing breathlessness with opioids or lorazepam, for instance, and providing support.
The prognosis mentioned here, though, 50% die within 3 years. It's stark.
It is. But this section shows that even without a cure, a really active, team-based approach makes a big difference to quality of life and can, according to the notes, modestly extend survival with things like riluzole, NIV, and PEG.
Which brings us directly to prognosis. What's the overall outlook? The notes are pretty blunt, progressive, and fatal.
Yeah, unfortunately, that's the reality. Survival time varies, but the notes state it's typically 2 to 5 years from when symptoms start. Median survival is around 2 to 4 years.
What makes the difference in how long someone survives? What factors do the notes point to?
Several things seem to influence it. Older age at onset usually means shorter survival. Having bulbar onset to speech and swallowing problems starting first is also linked to a poorer prognosis. How fast the disease progresses initially is a factor too. And early respiratory involvement is a bad sign. The notes specifically list things like significant weight loss, poor scores on breathing tests, a low ALSFRS score, that functional rating scale, and a shorter time between symptoms starting and getting diagnosed as predicting shorter survival.
But didn't the notes also say some people live much longer?
They did, yeah. It's an important point. Despite the average, about 5 to 10% of people survive 10 years or more. So there's definitely variability in the progression rate.
Right. And finally, complications. What challenges do people face as it progresses?
Respiratory failure is the main cause of death eventually. often alongside pneumonia from infection or aspiration. Other issues noted include infections like UTIs, skin breakdown from immobility, the muscle problem spasticity, cramps worsen, immobility leads to disability, depression is common, loss of speech is devastating, and the notes mention that sometimes, though less commonly, cognitive function can decline too. And again, the notes stress that palliative care is key for managing all these complications and supporting the patient and family right through the journey.
Okay, wow. So we've covered a lot: the definition, causes, risks, the pathophysiology, that NLMN thing, who gets it, what it looks like clinically, those key diagnostic clues, how it's investigated by ruling things out, the huge role of the multidisciplinary team in management, the prognosis, and the complications.
Yeah, we've really distilled those revision notes, I think, moving from the basics right through to the complexities of diagnosis and the focus on quality of life and management, despite the prognosis.
What really sticks out for you from all this, for me, it's got to be that unique NLMN mix, the crucial absence of sensory signs for diagnosis, and just how vital that whole support team is.
Definitely. And it raises that interesting question, doesn't it? That 5–10% who survive much longer. Why? What's different about their biology or the disease process in them? If we could figure that out, well, that could unlock so much. Definitely something that needs more research.
Absolutely. A key question for the future. Well, thank you for joining us on this deep dive into motor neuron disease based on these revision notes. If you are revising for something like the MSRA and you're looking for more resources, pass the MSRA.com and also freemary.com.
Until next time, keep diving deep.